checking your eyes really quick. I'm just really looking at your pupils to make sure that they're well equal, rounded, and all that, okay? So I'm gonna like you just look straight ahead. Okay, Peripheral was good and normal. All right, I'm actually gonna check into your mouth really quick, see if you can open that for me. Okay, tongue looks pink and moist. Teeth look normal, white, and strong, and her mucous membranes look healthy. Okay, I'm gonna look in your nose really quick. Okay, nostrils look good, not too much of anything inside, and look dry. So I'm gonna check your ears. Okay, ears look bilaterally symmetric, and then I'm gonna look inside, but I'm really not gonna look too in depth because I would need an otoscope for that. Okay. Okay. Okay, they look normal, not too much discharge or anything. All right, I'm gonna check your throat. Does that hurt?
No.
No? Okay. Looking at her skin, it looks well, healthy, dry. There isn't any abnormalities like bruising. It looks intact. Okay, I'm gonna check your range of motion, okay? So I want you to put your hands out like this and then put them to the side like that, each one. Okay. Okay, does that feel okay?
Yeah.
All right, and then with your feet, I'm just gonna be bending your knee and then just kind of go to the side a little bit. Okay, good. Does that hurt?
No.
Okay. Muscles look normal and symmetric, and range of motion was normal. So I'm gonna have you put your hand out like this. Okay, and then I'm gonna push down, and I want you to push up. Okay, so like that. Great. Okay, and I'm gonna push up, and you push down. Okay, same thing with your feet. So I'm gonna push up towards you, you're gonna push down towards me. Good. Okay, and then push down towards the bed, and you're gonna push up kind of towards the sky. Good. Strength was bilaterally the same, strong and purposeful. Okay, so I'm just gonna check your capillary refills, okay? Okay, less than 3 seconds, so that's good. And then I'm gonna take your socks off, is that okay? Is this your,
My service cat.
your service cat? Okay. So I'm gonna check your pulse really quick. Pedal pulses are about a +3, so that's normal and not bounding. I'm just gonna check here the integrity of your feet, okay? Feet look normal, nothing abnormal about them like blisters. They look dry and intact. And put these back on, okay?
Okay, thank you.
Actually, let me check the capillary refill real quick. Okay, less than 3 seconds, normal again. All right, and then I'm just gonna check your pulse on your wrist as well, okay? Okay. Let me check that real quick. So I'm gonna pretend like that. Okay, so those are normal as well, not bounding or anything is abnormal with them. All right, so I'm gonna do my assessment now. I'm just gonna be looking at your lung sounds and your heart, okay? So actually, let me clean this first. Okay.
It's very emotionally attached to.
Okay. So because I cleaned it, it can be a little cold, but I'm gonna put it against my skin so it's not, okay? Hopefully. Okay, this shouldn't be too bad. All right, so I'm gonna move your hair, is that okay?
That's fine.
Okay. All right, and then I'm gonna have you breathe in and out. Again. Okay, put it to your side. There you go. Okay, and then I just checked your anterior, so I'm gonna check your posterior. So if you could sit up for me really quick, just straight. And then can I move your hair again?
Yeah.
Okay. Now move to the side. Okay, and then breathe in and out for me again. Okay, and you sit back down. Okay, I'm gonna take your apical pulse, which is just like right where your heart should be, like right at the tip of it. Okay. So I'm gonna take it for a full minute, okay? Okay, apical pulse is normal at 75, so that's good. All right, so I'm gonna do a bowel assessment. So I'm gonna do it right now, so I'm just gonna look at it real quick. I'm just gonna uncover this a little bit, okay? Your bowel doesn't look distended, or your abdominal doesn't look distended or anything. Have you been bloated or anything lately? No. Okay. So I'm first gonna hear it, and then I'm gonna palpate, okay? So I'm gonna pull this down just a bit. So bowels not hypoactive or hyperactive, just a little bit of sound, but that's normal, okay? So I'm gonna palpate a little bit just in each quadrant, and you tell me if you feel any pain. Okay. What sound bit? Any pain at all?
No.
Okay, abdomen is firm but soft. I don't feel any distension or anything abnormal about it, okay? Muscles look symmetric and normal. Put this out of the way. Okay, so now I'm gonna assess your gait. So what that means is that I'm just gonna have you sit down on the bed. I'm gonna make sure that you don't feel dizzy first, and then you're just gonna walk towards that door and then back, okay? Okay. So sit up. Do you feel dizzy at all? No. Okay, can you stand? Dizzy still? Okay. No. Okay. All right, so if you wanna walk towards that wall. Great. Okay, thank you. Gait was normal, nothing shuffling or abnormal about it. Okay, if you want to sit back, it's fine. Great. Okay, so I'm just gonna ask you a few more questions. How's your elimination? So how are you peeing, pooping? Do you have a schedule?
Not really a schedule, but it's like pretty regularly.
Okay, and peeing fine? Yeah. Okay, the color, smell, everything's okay?
Yeah.
Okay, good. All right, and then what about your diet? How is that looking?
Honestly, I eat a lot of quick, like refrigerated foods, like ramen or like Hot Pockets mostly.
Okay.
Yeah, it's just like quick. Yeah.
Okay. Do you have any fruit or vegetables in your diet right now?
No.
No? Okay. Do you like fruit and vegetables?
I like strawberries, like bananas.
Okay. You know,
Did you like and she is active, and we're going to go ahead and start the assessment by looking at her skin. She is warm, she is dry, she has elastic skin turgor, and then next we can look at her head. She has no lesions or masses noted. Her head's non-lesionable and non-massable. It's round, equal, a normal size. We're going to go ahead and just put our fingers through her hair, look at the distribution. It's evenly distributed, no alopecia noted, no lesions, scaliness, or any rashes noted. Then next we can go ahead and check her sinuses. So I'm going to push on her frontal and tell me if there's any tenderness.
No.
No swelling either, and then that's the maxillary. And now I'm going to check her for TMJ, and I'm going to feel right here, and go ahead and open your mouth. And no clicks or snags or catches noted. And go ahead and open your mouth one more time. Fantastic. Okay. And now we are going to go ahead and assess her vision, and she doesn't wear glasses. We're gonna do OD, which is the right eye, so cover your left.
Oh.
And read that line.
DHJBS.
Okay, that eye's 20/20. Now we're gonna do OS, which is the left eye, and read that line.
DHJBS.
Okay, now we're going to do OU, which is both eyes, so read the same line.
DHJBS.
All right, great. So she has 20/20 in OD, OS, and OU, all visual sights. And now we're going to go ahead and check and look at her sclera and her conjunctiva. Her conjunctiva is pink, no drainage, sclera is white and vascular. Pink, no drainage, sclera is white and vascular. And also we're going to look at her pupils, look far in the distance, and I'm going to cover one eye at a time and look, one eye at a time and look. Her pupils are equal, reactive to light, round, and also we're going to check accommodation, look off in a distance, and I'm going to take this closer to you and you can focus your attention to it, and pupils do accommodate to objects moving closer. Next we can go ahead and test for visual field, so I'm going to have you cover your left eye, and I'm going to take my fingers coming in and tell me when you see them moving.
See them.
And tell me when
I see them. See them. See them.
Okay, now other eye.
I see them. I see them. See them. See them.
Fantastic. All right, so she has appropriate visual fields. We can go ahead and check for ocular movements. So focus on this pen. I'm going to go look up and down, and what I'm looking for, as well as ocular movements, is nystagmus. So I'm looking for her eyes to jump up and down. She does not have any of that present. And also next we can go ahead and check her ears. We'll do the red reflex of her eyes, and we'll start this at 0, and I'm going to have you cover your other eye, and I'll look with this eye as well. We're going to look with the same eye, left eye to left eye. So I'm going to just feel her and then move in and find that red reflex, and it's present. You can see the orange glowing off the fundus, and we'll go in and go around and look for that. Oh, there it is. Okay, so she had the red reflex present in both eyes, and no issues with that. Next we can go ahead and look at her ears, and the exterior of them, which is the auricle and the canal. No redness, tenderness, lesions noted on either side of them. And then we can go ahead and look at the canal. Pretty clean, no redness noted on either side. Oops, sorry. Okay, and I'm going to just go in a little bit further and look at her tympanic membrane, and I'm looking at that cone of light, and I see that her tympanic membrane is pearly gray, translucent. No discharge or redness noted. Do you notice any tenderness when my thing's in your ear?
No.
Okay, this is pearly gray, translucent as well. We can go ahead and perform the tug test. So I'm going to take the auricle of the ear, and we're going to go up and tell me if you feel any tenderness.
No.
Down. We're going to push in her tragus. Any tenderness. Okay, now we're going to do the hearing test. So I'm going to have her cover one ear. I'm going to repeat, or say 3 words. She's going to repeat them. 2, 3.
1, 2, 3.
Okay, and I'm making sure she can't see my mouth or lips move. I'm back here.
1, 2, 3.
Okay, so she does fine there and is able to hear. Oops. And next, we are going to, before I move on to the mouth, or the nose, I will go ahead and feel for her lymph nodes. So we're going to start with pre-auricle, post-auricle. We can do tonsillar, submental, submandibular, post-cervical, and also anterior superficial cervical. So no swelling, any tenderness,
No.
And no nodules noted. Okay, next we can look at her nose. The exterior is equal, symmetrical, no swelling noted on the sides. And I'll go ahead and look on the inside of them. So I'm going to be looking, no deviated septum noted, and also her tubercles are not swollen or inflamed. Next, we can look in her mouth, and we're going to inspect her lips. They are pink and not cracked. Go ahead and smile. Her teeth are intact, no history of no evidence of dental caries. I'm going to look at her gums. Her gums are pink, not bleeding. Do you ever have evidence of bleeding or bruising anywhere? And go ahead and say ah. Her tongue is pink, wet, moist, and say ah. Pharynx is pink, and no redness or rashes or any papules noted. And also the palate of her mouth is pink and intact, and not cracked or shows any redness or bleeding. Let's see, after that we can go ahead and inspect her neck, and we're looking for a trachea, no deviation noted. Go ahead and lean back. We're going to look for any jugular vein distension. Move your head that way. No jugular vein distension noted. I can see her pulsations, and go ahead and sit back up. And also I'm going to notice any nodules, masses, lesions, none noted. I will go ahead and feel for her thyroid, and we're going to feel down here. Go ahead and take a drink. Okay, thyroid moves up and down, no nodules, tender. Is it tender?
No.
And swelling, it's even and equal. Okay, and I can go ahead and listen to her carotid arteries. No bruits noted. Next, we can go and look at her chest. We're going to look at her precordial area and her chest wall. No lesions, masses, any abnormalities. It's symmetrical. And then we can go ahead and palpate for any heaves or thrills. So we'll start at the aortic, feeling for heaves, and then this is thrills. So no rise of my fingers. We're also checking for pulsations. Now that's pulmonic. And then we're going to check the apex, which is the mitral. So no rise of the fingers on heaves, and then no vibrations with thrills, and then or pulsations. Tricuspid, and then also substernal. So no pulsations, thrills, or heaves noted. We can go ahead and listen to her heart sounds. I'll start at Erb's point, and we're going to listen with the bell. We're going to listen for at least 3 cardiac cycles. Aortic, pulmonic, mitral, tricuspid, all right, so she had a regular ring rhythm. I heard S1 and S2, no murmurs noted. I can also go ahead and palpate for any of her substernal enlarged lymph nodes. She has none present. And then we can go ahead and move on to respiratory. And we will go ahead and start by inspecting the anterior, posterior, and lateral chest. No lesions, masses, or rashes noted. Go ahead and breathe in for me. Symmetrical chest rise, And I can go ahead and feel for a symmetrical chest rise in the back. Go ahead and breathe in. It's equal on both sides and even when she's breathing out. I can go ahead and check for any tactile fremitus. Say ABC, 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 ABC. Alrighty, ABC, 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 ABC. And I can feel the vibrations on the ball of my hand. And we can go ahead and move on to palpation. So I'm just going to feel for any masses or lesions or any nodules noted on any anterior or posterior side of the heart or the chest walls. Now we can move on to percussion. We're going to percuss anteriorly, so we're noticing that it should be resonant and should go to dull when she gets back to the diaphragm, and then turn around for me. And we're going to go ahead and percuss on the back as well. So we'll go right 1, 1, 2, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7, 7. So it should be resonant from about 4 and above, and then gets dull about 4, below 4, where that diaphragm is. And I'll go ahead and listen to her lung sounds posteriorly. Big breath. And again. And again. Again. And again. And again. And again. And again. Okay. Again. Again. And we're going to go ahead and listen anteriorly. Okay, lung sounds clear in all areas, air is moving freely, and no bronchi, wheezes, or crackles noted. Next, we can go ahead and go to her abdominal assessment. I'll have you lay down. Okay. And inspection, the contour of her belly, it is round. And it is symmetrical, no lumps or bumps, lesions, masses noted, and I don't see any pulsations anywhere. I can go ahead and start by listening to her bowel sounds. In all 4 quadrants, we should listen a minute apiece. Bowel sounds are gurgling, and they are active, so frequency and character is noted on that. Next, we can go ahead and percuss all 9 areas. We'll start with the right hypochondriac, epigastric, left hypochondriac, left lumbar, umbilical, right lumbar, right iliac, inguinal, suprapubic, left iliac inguinal. Alrighty, and then now we can go ahead and percuss for her.
We'll be assessing Savannah's active range of motion and ankle dorsiflexion. To do this, I'm going to first put my patient into talar neutral by finding the talus, putting her into dorsiflexion and plantar flexion and abduction, inversion, eversion, until those tubercles are nice and aligned, and then I'm going to ask her to hold this position right here. I'm going to put the fulcrum in the center of the calcaneus by drawing the fibular line down and then bringing the 5th metatarsal line out, so right about here. The stationary arm is going to be in line with the fibula, and then the moving arm is going to be in line with the 5th metatarsal. So right now she is in about a 20 degrees neutral angle, and then I'm going to ask her to bring her foot up to the sky into dorsiflexion, keeping that same goniomic alignment. She has about 25 degrees of dorsiflexion. Now I'm going to compare bilaterally. Again, starting by putting her into talar neutral. Right here, hold that position. Same goniomic alignment. Bring that fulcrum in the middle of those two lines. Stationary arm along the fibula. Moving arm along the 5th metatarsal, bring that foot up. She started at about 20 degrees and she is ending at about 25 degrees of dorsiflexion. The normal range of motion for this motion is 20 degrees, and Savannah was a little bit over both of her ankle dorsiflexions for both sides. I'm now going to be assessing Savannah's subtalar joint medial glide passive range of motion. To do this, I'm going to first put our patient into talar neutral by aligning the talar tubercles so that they are in line here. And then I'm going to put my index finger just distal to the medial malleolus to block the talus, gripping the calcaneus, and then providing a straight medial translation to assess the deep ligaments of the subtalar joint. I'm then going to compare bilaterally. Again, putting her first into talar neutral here, blocking the talus with my index finger distal to the medial malleolus, and then providing a straight medial translation to the calcaneus. The infield here should be firm, and Savannah had firm infields when compared bilaterally. I'm now going to be performing a grade 5 manual muscle test for eversion. To do this, I'm going to have my patient lying on their side with their affected leg up, stabilizing the lower leg, and providing resistance to the lateral and plantar aspect of the foot, instructing my patient to bring their foot up towards the ceiling, hold for a second, and then going back down. To isolate the peroneus brevis, I'm going to apply resistance just to the lateral border of the foot. Go ahead and come up, hold for a second, and back down. And then to isolate the peroneus longus, I'm going to apply resistance just to the plantar surface of the first metatarsal head. Go ahead and come up, and back down. I'm then going to compare bilaterally. Again, stabilizing the lower leg, applying resistance to the lateral side to isolate the peroneus brevis. Go ahead, come up, and back down. And then on the plantar surface of the first metatarsal head, come up, and back down for the peroneus longus. Compared bilaterally, Savannah passed the grade 5 manual muscle test for eversion because she was able to resist max resistance and hold a break test at the top. I'm now going to be performing the anterior drawer test. This test has a sensitivity of 24 to 84 and a specificity of 60 to 100. This means that this test can rule in and out pathologies. However, since the ranges for specificity are higher and have more numbers over the 80 mark, this test is better at ruling in pathologies. To do this test, I'm going to have my patient lying supine. I'm then going to put her into talar neutral. I'm going to grip the tibia and the calcaneus and provide an anterior translation and assess the infield. I'm then going to compare bilaterally, again putting into talar neutral, gripping the tibia and the calcaneus and providing an anterior translation, looking for ligament laxity and pain. This test assesses for lateral ankle sprains, specifically of the anterior talofibular ligament, and this test is positive if the patient reports pain or if there is ligament laxity. Again, this was the anterior drawer test, and Savannah had a negative test when compared bilaterally. I'm now going to be performing the external rotation and dorsiflexion test. This test has a sensitivity of 20 to 71 and a specificity of 63 to 85. This means that this test is moderately good at ruling in pathologies. To do this test, I'm going to first put the patient into talar neutral. I'm going to grip the calcaneus and stabilize the lower leg, maximally dorsiflex the foot, and then externally rotate. I'm then going to compare bilaterally. Again, putting the foot into talar neutral here, gripping the calcaneus, stabilizing the lower leg, maximally dorsiflexing, and then externally rotating here. This test is assessing both the anterior and posterior inferior tibiofibular ligaments, the deltoid ligament, as well as the interosseous membrane. This test could indicate sprains of all three of those structures, and the positive test is pain over the site of the structures or pain, shooting pain, up the lower leg to the point where the tear is on the interosseous membrane. Again, this was the external rotation and dorsiflexion test, and Savannah had negative tests when compared bilaterally. I'm now going to be palpating the base of the fifth metatarsal. I'm going to start by finding the fifth metatarsal on the lateral edge of the foot and palpating my way down until I feel a bony protuberance right here. And then to verify that I'm on the base of the fifth metatarsal, I'm going to have her actively evert her foot, so bringing that foot out and feeling the contraction of the fibularis brevis right here on the insertion. Then I'm going to compare bilaterally. So coming to this side, again, walking my way down the fifth metatarsal until we hit that protuberance, and then having her evert her foot, bringing the foot outwards, and feeling that contraction of the tendon underneath my fingers. And she had normal palpations of the base of the fifth metatarsal when compared bilaterally. I'm now going to be palpating the anterior tibialis tendon. To do this, I'm going to find the tibial crest and ask my patient to flex her foot upwards. Just go laterally till we find the anterior tibialis muscle belly. Relax. Follow that muscle belly all the way down to the most medial side of the ankle right here. We feel the tendon here, but to confirm that we're on it, I'm going to have her push up against my hand, and it should contract right here, and then also push inwards against my hand, feeling that contraction right here. I'm then going to compare bilaterally, again finding the tibial crest, going just laterally, feeling that muscle belly. Relax. Following that muscle belly all the way down till we find the tendon on the medial side of the ankle here. Resisting dorsiflexion upwards should make that contract, and then also resisting inversion, pushing in against my foot, making that tendon contract here. So then I had normal palpations when compared bilaterally.